After discussing the basics and the concept of compliance and the application of PEEP in episode 5A, in 5B, we are going to practically apply now these concepts in a spontaneously breathing patient and a ventilator patient. So let's just discuss now static and dynamic compliance of a spontaneously breathing patient. Now we know that a change in transpulmonary pressure results in inflation of the lung, right, in a spontaneously breathing patient. This transpulmonic change in pressure and the volume accommodated at maximum level when there is no flow is static compliance. So at end inspiration, when there is no flow, static compliance can be calculated as the tidal volume or the volume change in the lung divided by change in transpulmonary pressures, right? We've already covered it in lung mechanics that at end expiratory phase, the intrapleural pressure is -5 and it shifts to -8. So the net difference is of 3, right? So a 70 kg man with 7 ml per kg of tidal volume generates around 500 ml of tidal change for a net change of transpulmonary pressure of 3, and the compliance would be around 166. Normal value 100 to 200 ml per centimeter of water. What about dynamic compliance? As the word dictates, dynamic or airflow, right? So wherever there is airflow, then the compliance calculated is dynamic compliance. Now, in terms of lungs, don't you think that there must be some compliant system in the airways as well, right? So we've already covered that flow is change in pressure divided by resistance, right? So whenever there is pressure gradient, flow is established. Now this will be covered in laminar versus turbulent flow later, but overall from this equation you can see that resistance, if increased, would require greater change in pressure to maintain the same flow, right? If I were to talk about flow of water from the mountain top, let's say P1 to P2, right? If I were to place logs and trees in the path of water and some stones as well, what would it do? It would increase the resistance to flow. Now in order to maintain the flow, the pressure needs to be changed, it needs to be increased. In other words, compliance is reduced when resistance increases, right? Suppose instead of trees and rocks, we have mucus and secretions in the airways. It would increase the resistance, decrease the flow, and in order to maintain the same flow, greater pressure would be required, and this would reduce the compliance of the airways. Let's suppose if we were to calculate the static and dynamic compliance of a ventilated case, right? So in a ventilated case, let's draw a patient with ETT and connect it to a ventilator. Now we know that the diaphragm is key muscle of spontaneous breathing, but in a ventilated case, through neuromuscular blockers, the diaphragm is paralyzed, right? As a result of which, diaphragm will not move downwards, so the intrapleural pressure will not change. Now in order to generate flow, we will have to increase the pressure from above, and this is where positive pressure ventilation of ventilator comes into play. The ventilator would increase the pressures greater than the alveolar pressure of 0, and due to this pressure gradient, flow would be established. So when flow is generated through the breathing circuit, ETT and airways, it would try to overcome the resistance. This is called the peak pressure until the inspiration arrests. This is where no flow would be present, and where there is no flow, there is no pressure gradient, right? This is the basis of calculating the alveolar pressure. So at this point where there is no flow, the alveolar pressure would be the same as the one being registered on the ventilator, right? And that is called the plateau pressure. Now, how would we see these pressure curves on a ventilator screen? Initially there is end expiratory pressure, right? So in order to initiate breath, the ventilator would give a positive pressure from above, as a result of which flow would be generated from P1 to P2. Now initially this flow would try to overcome the resistance of the airways as well. So greater pressure gradient would be required to generate flow. This is called the peak pressure, which is green in color. Once flow is established, the lungs would inflate until there is no flow or end inspiratory phase, right? This is where the pressure at alveolus and the pressure in the alveoli would equalize. So this would create a plateau in the graph. This is called the plateau pressure. And why it is lower than the peak pressure? Because peak pressure was used to overcome resistance, right? But in no flow state, there is no pressure gradient, there is no resistance. So the pressure drops. This is registered as the plateau pressure, which is the true alveolar pressure. So to sum it up, peak pressure would be all about pressures through the airways, overcoming the resistance, whereas the plateau pressure would signify the alveolar pressures, the true alveolar pressures at the end of inspiration when there is no flow. So how would we calculate the static compliance of a ventilated case? Through inflation hold, right? This is a command given to the ventilator. Once the peak pressure is reached and end inspiratory phase starts, through inflation hold there is no flow and the pressure registered on the ventilator is the plateau pressure. So the tidal volume delivered divided by the plateau pressure is the static compliance. So let's just be practical about it. If I were to say that I were to see peak pressure and plateau pressure on a ventilator and suddenly peak pressure increases but the plateau pressure remains same, what would that indicate? That would indicate that something is wrong with the airways, right? It starts from the breathing circuit all the way down. So I would be suspecting kinking of airways, bronchospasm. Anything that increases the resistance would require greater peak pressures, right, to overcome the resistance of the airways and generate flow. What about a case where peak and plateau both increase? Now this is a situation where I would be suspecting decreased compliance in the lungs as well. We've seen that the static compliance is tidal volume divided by plateau pressures. So when plateau pressures are increased, the compliance reduces. So I would be suspecting any anomaly in or around the lungs, such as abdominal compartment pressing onto the diaphragm, right? Or I could suspect pneumonia or ARDS, where lungs are involved and the compliance system is starting to reduce. Or if there is air in the intrapleural space, like in pneumothorax. So plateau pressure and its value basically tells us about the static lung compliance of ventilated patients. Let's take ARDS again for an example. In ARDS, we know that the compliance system is reduced, right? So plateau pressures would increase. Now, as per ARDS net protocol, we need to keep the plateau pressures below 30. Why? Because above 30, we've already discussed that it would cause rupture or barotrauma of healthy lung as well. Now, how would I reduce the plateau pressures and improve the compliance? I would give PEEP, right? So, through PEEP, compliance would improve and we would keep the lungs above the lower inflection points and into the green zone or more compliant part. This way, compliance is increased. So by keeping plateau pressures less than 30, we would prevent barotrauma. And by giving PEEP through the ventilator, we would be recruiting the diseased alveoli in the next breath. This is called recruitment of the diseased alveoli. So this is where PEEP helps in improvement of the compliance. Now the whole equation of static compliance is tidal volume divided by plateau pressure minus PEEP, right? So higher the PEEP, lower would be the value of denominator and higher would be the compliance, right? So this is how PEEP helps in improving the compliance of the lungs. This is all for today. I think we have been able to understand the basic concept of compliance and how to apply that concept through various diseases in a spontaneously breathing or a ventilated case. Stay tuned for the next episode.